Well, so thank you very much to the organizers and to all of you for inviting me to share the morning with you and talk about something that's really dear to my heart. Before I get started, I actually want to get to know you all a little bit better. How many of you in the audience have dystonia? Okay. Normally I start that with how many people know someone with dystonia, but I figured in this group that was probably a pretty silly question. In the audience, how many people have had surgery for dystonia? Okay. And of those who have had surgery, how many have had deep brain stimulation? Okay. So I may not, please put your hand down. I may not have a lot to teach many of you because you have a lot more firsthand experience with surgical therapy than I do. But one thing I do want to emphasize is how important each of you is to solving this critical problem of the treatment of dystonia. Most of the time, or many of the times in medicine, we have animal models, we have examples, or we have a really uniform population to study to understand a disease and what its treatment is. So progress is very rapid. As you heard in the previous talk, and I'm also going to emphasize, dystonia is a collection. And therefore, really our progress relies even less on us than it does on you. And it's groups like the DMRF and people like you who really help us to advance the field. And so for those of you who have participated in research, I want to thank you. And I know in our own program, we really rely on our patients to help us to understand this disease better. So with that, let's see. So dystonia for a neurosurgeon is essentially a symptom, or I should say a sign. Symptoms are what patients tell doctors. Signs are what doctors observe in patients. So a sign is what we find on examination. And essentially dystonia, more or less, is the involuntary co-contraction of opposing muscle groups. Now, creating that situation can be lots of different disease processes. And in fact, people have recognized dystonia for many, many centuries. In fact, if we look at ancient cave drawings, there are drawings of people with dystonia. So it's been around a long time. In fact, surgery for dystonia has also been around for almost 400 years. So in 1641, there was a publication of a German surgeon who would try to cut muscles to treat dystonia. I have to admit that the risk-to-benefit ratio of that surgery may not have been what we would do today, but they were trying even back then. As you heard, Dr. Oppenheim was the first to coin the term for dystonia, and as you can imagine, even now, but especially then, people didn't understand what dystonia was. It was a question of, is this some sort of demonic possession? Is this a disease? You know, what causes it? Because of the ignorance, there was a lot of misunderstanding. And I'm sure, unfortunately, all of you who have dystonia still experience that today. So the clinical features of dystonia are quite varied. And some of these things are dystonic posture, so co-contractions of opposing muscle groups causing changes in your posture. There are movements, so you can have fast and slow movements, there can be tremor, and so on. There are these mysterious things that can help with dystonia. One is called geste antagoniste, so this is when someone, for example, has cervical dystonia, and they can put their hand on their cheek and write their dystonia. Actually, I can see in the audience a couple of you using that trick. And then there's mirror dystonia, which is where the unaffective side is affected during repetitive tasks. And then also overflow dystonia, where it spreads beyond its normal area. I can tell you from time to time when I'm operating, I experience a little bit of dystonia because I get essentially a cramp from these repetitive movements that I always do. So many more people are familiar with dystonia than those who can name it or describe it. As you heard, there's a very complicated classification of dystonia now. This is a summary of what you heard in the earlier talk in much greater detail, but essentially the sources of dystonia can be different, the distribution of dystonia can be different, and the onset of dystonia can be different. And what's really critical to us who are treating patients with dystonia, and particularly to surgeons, is that how we classify dystonia help us to educate our patients about how they're going to do and what the risks to benefits are. The caveat is that we can't predict the future. And so even the best surgeons in the best programs doing the surgery perfectly well cannot tell you exactly how it's going to go for you. And that's just part of the price of doing business. But one thing that we do know is that we can classify something about what our expectations are. For example, childhood dystonias tend to become more generalized. Adult onset dystonias tend to stay more localized to where they appear. You saw this model because one of the questions that we're all asking is, how does dystonia occur? And so I wanted to take just a second to talk about this because I think it's important to understanding what deep brain stimulation is. So in our brains are circuits, just like computers. And you've got lots of chips and they're connected by wires. And signals in one chip talk to the next chip, and the next chip talks to a third chip, and then it can loop around. And so imagine that you dump a little bit of water on the circuit board of your computer, or as I did once, I took my iPhone for a swim. Well, things don't quite work properly, and then after putting it in a bag of rice and praying a little bit, you pull it out and very gingerly turn it back on, and sometimes it works just fine. And so what's happening in dystonia is we can measure electrical activity and we can measure chemical activity inside the brain, and what we can see is that it's different. In the end, we don't know exactly why it's different. We don't even quite know how it's different, but we know that it is different. And so the surgical strategies, either with chemicals or with electrical stimulation, is to alter the way those signals are traveling in order to relieve the symptoms of dystonia. So, what is the pathophysiology? I can tell you that I personally understand this slide about as well as you do. I'm an engineer by background, not a molecular biologist, and to me, the numerous advances in the genetics of dystonia kind of get a little bit like alphabet soup. But what I take away from that is that we're learning a lot more about what the sources of dystonia might be. We're learning that there are multiple identifiable causes that all feed into some sort of pathway that result in this sign, this opposing co-contraction, or this co-contraction of opposing muscle groups. And that hopefully that will help us to classify how patients will respond to different therapies. If we know that you have, alphabet soup ABCD kind of dystonia, then we maybe eventually be able to say, okay, these 3 drugs work for that, these 2 surgeries work for that. Whereas if you've got XYZ kind of dystonia, then maybe DBS will not work and we should try something else. And that's where we're all headed. So what is the treatment of dystonia? As you heard, we have non-surgical therapies, and you've heard a little bit about them already. You're going to hear more about them later. The major important thing is that any therapy for any disease is a matter of thinking about risks and benefits. My favorite surgery is not DBS. My favorite surgery is the surgery I don't have to do because I find something that's less risky and more effective for my patients, and I get to spend my time in Chicago talking to folks like you instead of in the operating room. But the point is that we do have some very effective therapies that unfortunately don't work for everyone. And I think the frustration for patients is to go to an expert, to be given a medicine, and then find that it doesn't work. and then try another medicine and find that it doesn't work. The thing that's difficult is that the third one may work well for you, and therefore I would suggest, as has been suggested before, that go to someone who's an expert, who really understands what the spectrum of medications is, what the spectrum of possible interventional therapies is, and give them the opportunity to try the different things to find out what works, keep track of what the responses are for you, and report them. The best decisions that we make come from the information that you give us. If the information that we receive is not accurate or is colored by what you think we want to hear, then we can't advise you well. And that's true in medicine, and it's true in surgery. So, what are the current surgical therapies? Well, they're listed here, and essentially there are two different approaches to the treatment of dystonia. One, like our famous German surgeon in 1641, is to try to address the muscles that are being affected. The other is to try to deal with the problem in the brain. Both of the approaches have value. So selective peripheral denervation is a procedure that is done where the nerves going to the affected muscles in the neck are essentially cut. And it takes time for them to come back, and therefore during that period of time, patients, experience benefit. This is actually can be quite effective for patients who have dystonia in their throat, and was very popular before the advent of botulinum toxin as a treatment. Intrathecal baclofen I put under peripheral because it is a way to treat the reflex arc, and so therefore it tunes what these muscles are doing. In the brain, we have two different approaches. One is the older approach, which was to create a small lesion, i.e. we're creating a little stroke or, killing a few cells and so on. And by knocking out the right cells, we can improve symptoms. Deep brain stimulation actually grew out of these, what we call ablative or destructive neurosurgical procedures. And so finally, the now reversible effective therapy that we have is deep brain stimulation, and that's the last one. So what I'm going to talk about are the two most common therapies, surgical therapies today. One is intrathecal baclofen, and the other is deep brain stimulation. So what is baclofen? Baclofen is a chemical that I believe was originally developed for seizures that acts on the nerve terminals. So the way the brain communicates is one cell releases chemicals into a gap that are picked up by the next cell. And what happens is some of those chemicals that are released are detected by the faucet. And so that helps to adjust the faucet. And so what baclofen does is it goes back and it basically tricks the cell into thinking it has released more of the chemical than it actually has. And so then it adjusts how much is released. So it tunes this reflex arc, and that's particularly useful for spasticity. So what is spasticity? How many of you know what spasticity is? Okay, good. So spasticity is different from dystonia. Dystonia is the co-contraction of opposing muscle groups. Spasticity is a velocity-dependent increase in tone. What's the difference between those two things? In dystonia, your muscles are contracted, and your biceps and your triceps are contracted together, and so therefore your limb is locked. In spasticity, there's a velocity-dependent difference in tone, which means that moving fast is hard, but moving relatively slower is easy. It's a little bit like if you're trying to stir a pot. If that pot is full of water, it's pretty easy. If that pot is full of honey, the faster that you try to stir the pot, the more it resists you. And that's spasticity. Baclofen helps with spasticity much more than it helps with dystonia. Why is that relevant? That's relevant because dystonia, as we discussed, is not a disease. It's a sign. And some of you with dystonia have a lot of spasticity. And some of you with dystonia have very little spasticity. So who is going to be helped by baclofen? The person helped with baclofen is the person who has a lot of spasticity. So it's not just enough to have the diagnosis, but you have to have the sign that goes along with the drug. Okay, so the good news about baclofen for those of you who have spasticity is that there's very good tolerance of the drug, and its effects are largely sustained. It doesn't stop working that often, and there are different ways to take it. You can take it as a pill, or you can take it or you can take it as intrathecal. And let's talk about that. So the rationale for intrathecal baclofen, and I should say intrathecal means delivered to the spinal cord itself. The reason to do that is because baclofen taken by mouth spreads all over your body, and therefore you get side effects. And those side effects are sedation or confusion. It can be constipation. It can be bladder symptoms. One of my favorite patients with dystonia with baclofen, unfortunately both intrathecal and oral, gets terrible nightmares. That's her side effect. So all of these drugs may have what we call idiosyncratic side effects. Doctors like to use big words. It gives us, some security. Idiosyncratic means we're not quite sure, but it happened in this patient and didn't happen in that patient. Idiopathic means we don't know what's going on. But anyhow, the idea is that when you take oral baclofen, it spreads throughout your body, it has effects throughout your body, and you can have side effects. So when we use intrathecal baclofen, what we're doing is we're giving the baclofen directly to the spinal cord itself, and thereby delivering a much higher concentration locally. So if you take 100 milligrams of baclofen by mouth, that's essentially the same as taking 1 milligram of baclofen directly to the spinal cord. Now, if you have 1 milligram of baclofen that spreads out of the fluid that is surrounding the brain and spinal cord, then it essentially disappears in the rest of your body. So that's how it takes care of side effects. Basically, we deliver a small amount directly where it needs to go, and so if it spreads outside of that, it doesn't matter. It has few systemic side effects. The efficacy of oral baclofen, as I mentioned, for dystonia is marginal because it helps with spasticity, not dystonia itself. And it actually has been used very effectively for patients with dystonia who also have spasticity since the 80s. I should note that intrathecal baclofen is not approved for dystonia by the FDA. It's approved for spasticity, and that's why. So how do we deliver baclofen directly to the spinal cord? The way we do that is with a very sophisticated pump with a tube that goes into the fluid-contained container with the spinal cord within it. For a surgeon, it's an operation that takes about 20 minutes. We basically put in a needle, we thread the catheter, we make sure the tip of the catheter is where we want it to go, and then we tunnel the catheter underneath the skin and then put the baclofen pump, which is about the size of a hockey puck, underneath the skin in the belly. What happens when you run out of baclofen? Well, we're able to fill the pump with a needle, and how often does it need to be replaced? Well, every 6 years or so, the battery in the pump will run out. There are now a number of different pumps that are available on the market that can be used, but essentially they're all the same, and the doses can be adjusted through a remote control. Okay, so how well does this work? Well, there have been a number of studies that have been done. Ford did a very famous one in 1996. They looked at 25 patients with segmental or generalized dystonia. What they found is that half responded to the intrathecal baclofen dose, which means that we test patients ahead of time by injecting a small amount directly into the spinal fluid and see what the response is. 3 out of 13 reported sustained improvement. 5 out of 13 had complications. This was early days. And what they noticed was lower efficacy with patients with dystonia, 25%, and then for patients with spasticity. So that doesn't mean that patients with dystonia shouldn't think about intrathecal baclofen. What it means is that if you have more spastic components within your dystonia, then you should think about it more than otherwise. All right, so deep brain stimulation. What is deep brain stimulation? Well, deep brain stimulation is a brain pacemaker. The idea is, imagine an orchestra. If you go to the Chicago Symphony in the beginning, everyone is playing whatever they want to play, and the thing sounds like, a bunch of noise. And then suddenly an oboe starts to play, and everyone tunes to that oboe. And so what happens in deep brain stimulation is that we put an electrode into the brain, into a very specific spot, and we turn it on, and somehow those electrical signals tune the orchestra of the circuits within the brain, and the brain starts to sound good. So some orchestras are more responsive than others, and therefore some patients respond better to deep brain stimulation than others. I should mention that deep brain stimulation has a humanitarian device exemption that was granted in 2003. That's the FDA level of approval. That is a status that is given to treatments for diseases which are relatively rare. So it's hard to do the kind of large trials that are done otherwise. The primary target is the globus pallidus. There's a secondary target, which is the subthalamic nucleus. In that big circuit diagram, those two targets are actually next to each other, and so the signals flow from one to the other, and that's likely why these two targets both work. So how is DBS done? Well, I don't want you to run home and do it yourself, so I'm going to just tell you a little bit about it. Essentially what we do is we do an MRI of the brain, and that gives us a coordinate system, X, Y, Z coordinates, and we pinpoint where we want to go, and we put a little soda straw, not even a soda straw, it's a thick piece of spaghetti with 4 electrode contacts into that spot. We tunnel the wire underneath the skin to a battery that's typically located in the chest, and we turn it on and we tune it, and that's how it works. So how does it work? Let's take a look. These are videos that were put together by the UCSF group, and they're really some of the best ones out there in terms of showing what happens over time. So you all are familiar with this, and typically when I'm talking to a general group, I'll mention that, this patient probably has completely normal intelligence, completely normal, thoughts and ideas, but is trapped. And the amazing thing about deep brain stimulation is that in the short term, it can have a dramatic improvement on the motor symptoms. So here's that same patient you can see a little bit later. And what's remarkable about deep brain stimulation is that it actually improves over time in many patients. So you can see here the gait has become even more normal. At the risk of the person in this video being in this room, I have to say that it doesn't look like DBS does much for hairstyle. So deep brain stimulation for dystonia has been very, very well studied. This is a study that was done in 2005, and let's look at what it showed. Essentially, they looked at 22 patients with generalized dystonia. They did GPI, DBS, and they measured according to standard scales what the improvement was. And what they found, like we saw in the video, is that the improvements accumulate over time. There's kind of a quick response in the beginning and then a slow response. And in fact, when they looked at generalized dystonia versus segmental dystonia, what was found is that the same pattern was observed. So it looks like generalized dystonias and segmental dystonias, at least at the level that they were understood then, seem to both respond to deep brain stimulation, and they kind of respond in the same sorts of ways. I can tell you from personal experience that the truth is a little bit more complicated than that, so that some patients will improve in this expected way. Unfortunately, sometimes that patient who I mentioned who had the nightmares with baclofen had tremendous response to deep brain stimulation for about 3 or 4 months, and then it just stopped working, and we don't know why. And there are other patients who don't respond at all. We're starting to understand a little bit more about that through our understanding of genetics. So for example, patients who have DYT1 type of dystonia seem to respond better to deep brain stimulation than, for example, patients with DYT6. So what data is there for cervical dystonia? It's actually, as I mentioned, pretty good. If you pull together multiple patients from multiple centers, GPI, and look at GPI and STN, GPI seems to improve about 49%. STN is 34%. It's a little hard to really get a solid number in terms of which target is better. Different groups have different opinions about it. There are papers out in the literature, but we don't have large numbers of papers and large numbers of patients to really know the answer to which target is better for a specific patient. There are many people who have what's called secondary dystonias. What does secondary versus primary? Secondary means that we actually know what's causing it, whereas primary was the term given, or essential was given to diseases that in the past we didn't know what caused them. So primary generalized dystonia was generalized dystonia and we didn't know why. Secondary dystonia was dystonia and we had an idea why. So for example, tardive dystonia is caused by a side effect of medication, and that actually neuroleptic medication, and that responds very well to deep brain stimulation. Patients who have dystonia associated with cerebral palsy, for example, a birth injury or toxic injury, those don't tend to improve nearly as well. There are certain heterodegenerative disorders. PCAN is a genetic problem with metabolism, and that tends to respond quite well to dystonia. LUBAG is another X-linked Parkinsonism dystonic syndrome, which also responds well. If the MRI is not normal, meaning if there's a focal lesion, if there's evidence of a stroke, if there's evidence of some sort of developmental abnormality, then deep brain stimulation does not tend to work as well. And so this is a graph which on this side shows the amount of improvement. So this is the best, this is the worst. And here are a couple of categories: generalized, cervical, hand, cranial, axial, secondary, combined dystonias. And what it's showing is that responses are all over the map. There are some things in general. So when patients have generalized primary dystonia with DYT1, we expect them to do pretty well with deep brain stimulation. and other therapies. But there are other groups that do much more poorly. For example, as I mentioned, these patients with cerebral palsy. And so we're starting to learn more about who's going to benefit. And hopefully, well, as you mentioned, the rate of progress is incredibly rapid. And so we're learning a lot more. We know a lot more than when I started in practice 15 years ago. How does DBS work? I touched on that a little bit. We think that essentially there's a combination of an electrical and a chemical effect. It's helping to change the pattern of activity within the brain, maybe getting rid or jamming bad signals and creating good signals. But in the end, we don't know how deep brain stimulation is going to do in a given patient unless we try. Imaging is something that I think is going to be very exciting. You heard a little bit that at my institution, University of Michigan, people are looking at different chemicals within the brain and how they respond. This is a different group looking at activity within the brain with dystonia. I think as we progress in our understanding, due to patients like you participating in these sorts of studies, we're going to learn more and more about what DBS is doing, who DBS works on, and try to give you better predictions of how you can expect to do. So to conclude, deep brain stimulation and other surgical therapies are well established and can be very effective treatments. That generalized and regional dystonias tend to have similar outcomes, but the outcomes are not 100%. There are some genetic conditions like DYT1 which respond better than DYT6, and that there are some secondary dystonias that respond well. So in the community of people who are not movement disorder specialists or maybe aren't functional neurosurgeons with familiarity, they tend to be either overly optimistic or overly pessimistic about the outcome of interventions with dystonia. So it behooves all of us to raise awareness in the community through groups like the Dystonia Medical Research Foundation or any of the other great groups who are working to help educate the public about dystonia. And finally, of course, the mechanisms aren't completely understood, but we're learning more all the time. Thank you so much.